So I'm going to open the proceedings. Can I welcome you all very much and add my voice in recognising the First Nations people, but also pay respects to everyone in the room who's older than me. Because I think one of the things we need to recognise about our society now is that ageing is a privilege denied to the majority of people in the world. And we're a very lucky country because of that. Right. I'm going to start with talking about older people first, because you can't talk about aged care unless you talk about who the people are. And that's the most important bit. And I'm struggling to get this to move. Here we go. Next year, the baby boomers turn 80. And what a surprise that is. But look at the number of people. This graph, and I'm going to show you some graphs. You don't need to absorb it all, but if you want to ask me a question when we go to the panel, we can open these up again and show you. You'll see the big boom, the baby boomers are coming through. And in the next 20 years, about 20 to 40,000 more people a year are going to be needing aged care than are getting it now. And this is, of course, a problem for governments and taxpayers. It used to be that aged care was a lifestyle choice, and at age 65, you jumped in your car and you drove up to the nursing home. Maybe that was not actually how it ever worked, but that's how we like to think of it. The average age now of people going into residential aged care is 85. It's not 65 and it's not 75. And the average age of people needing support to live independently at home is about 80. But that wave of people who turn 80 next year, and look what's going to happen after that wave comes through. All those huge facilities and services we're building up now are going to be really have low occupancy, and this is an issue for government going forward. The second thing I want to say about us is that there's a perception that at age 65 or 67 now, we all stop work and go on the pension. Well, I can tell you at age 65, I was busier than ever, and many people are. But have a look at this. As age increases, so do the number of people on the pension. It makes perfect sense. In the young people, the 66 to 69-year-olds, 30% are on the pension. But by the age of going into aged care, about 80% of people are actually on a pension. And there's a perception that there's all these baby boomers, cashed up baby boomers, sitting around enjoying enormous wealth and fat superannuation schemes, when it's actually not like that. Now, there are some very rich people in the baby boomers coming into old age, and I don't have a problem with them paying for their care, but the majority of people, that's not the story. So one of the reasons for that previous slide is that people are doing what they're meant to do, which is start on superannuation, use that up and switch to the pension. But the other good news for women, not so good news for men, is that the majority of super is held by men, and they die off. And that's one of the reasons that we've got this very big boom. So looking at superannuation, if you're looking only at people over 85, because that's the average age of people going into residential care, only a quarter have any super by age 85. Only of that little group, 28% of people have got less than $40,000 in super. So this rich old age everybody's expecting isn't going to be the case for most people. A third have got less than $60,000. Only 13% of people have got more than $100,000 in super by age 85. That's the system working like as it's meant to work. We're not all meant to actually save all that money, deprive of ourselves of things we need in order to give it as a nest egg to our kids. Some people want to do that, but most people understand that the purpose of super is to fund our retirements and our years into old age. I'm going to give you a bit of background about aged care, and I will make a comment that there is a new Act of Parliament going through at the moment with a whole lot of changes, and we can talk about some of those. And I spent yesterday writing a quite scathing submission to the Senate inquiry about all the things that I think are problematic in it and all the perverse incentives they've created. But I want to give a bit of background first. And this is my first. In the eyes of governments and bureaucrats, aged care is not healthcare and healthcare is not aged care. And of course, for anybody who's getting older, that's a ridiculous idea that this bit of me needs healthcare and this other bit of me needs aged care. That is just completely crazy. But aged care is the responsibility of the Commonwealth Government, and healthcare service delivery is the responsibility of the state government. Although the Commonwealth funds general practice and most of the other day-to-day services people use, under the Constitution, healthcare is the responsibility of the states, and the other major service that people use apart from GPs and medications is hospitals, and they're completely run by the states. So that's our first big problem in aged care, is that somehow or other we've created a bureaucratic system that two levels of government who don't talk to each other and who see cost shifting between each other as an art form, not as bad social policy. This is what the major Commonwealth aged care programs are now. And the DVA still looks after veterans, and there's a couple of small programs as well. But I just want to point out, 2/3 of all people in aged care are getting services from a program called CHSP, or the Commonwealth Home Support Program, previously known as Home and Community Care. And that's where funding for things like Meals on Wheels, of which I am on the board of New South Wales Meals on Wheels, and community transport and day programs and some allied health and nursing is all funded. And they've been left out of the whole national reform. So that's a really important thing to know. And I have to say, well, having read the reform, the best thing that happened to CHSP is that they were left out. It's one club I don't want to be in. So I'm going to go back. For some reason, that just flicked on. Right, now it's got a mind of its own. Okay, we'll keep going. 20% of people are now getting what are called home care packages. Anybody in the room on a home care package? And this is a new industry that government has created, where instead of in CHSP, the government gives Meals on Wheels or community transport over a grant. In home care packages, it gives you a grant and it turns you into a consumer, and your job is to go off and buy things in the competitive private marketplace. And if you buy the wrong things, it's your fault, which has been a fantastic way of shifting financial risk onto older people while absolving both governments and providers. And guess what? The whole basis of the aged care reform is more of that and less of grant-funded services like CHSP. The other thing I want to say is that only 14% of people in receiving aged care are in residential care, which is not the image we have of residential care. We have this idea that the majority of old people go to residential care. The majority of old people never go to residential care, but that 14% consume about 2/3 of the total aged care budget.
Can I make a comment?
Yeah. You jump right up.
I'll speak here so people can hear. I'm a GP, and I have so many older people come to me and say they cannot work out how to access the aged care system. And I can see people all over this room nodding. And then I have the daughters come to me in their 50s, the sandwich generation, still ferrying people to school, looking after mum and dad. And they say, I cannot work out the aged care system. I cannot, we've got all these piles of papers and we don't know what to do. So it translates into, and so nothing happens, sometimes for several years until somebody helps. So this problem translates into very real suffering on the ground, not just for people in our age group, I'm also older, but for the next generation down who are trying to help us.
And also for the grandkids. So that brings me to the next issue, which is who among us does need aged care and why do we need it? And the first thing to say is we don't need aged care because we're old. And that's a really important point to make. The fact that you're old doesn't mean you need aged care. People need aged care when we develop health conditions. So the idea of split ageing and health all of a sudden starts to even be really stupid, because those health conditions lead us to lose our ability to manage independently. It's activities of daily living, ADLs as we like to call it in the jargon, which is the reason we need help and care as we get older, not because we're old. And ageing per se is not our problem. Our problem is the development of health conditions associated with old ageing that leads us to do things like losing strength and agility and movement, and also becoming increasingly frail, cognitive loss and behaviour. And I'm happy to talk about that in the question session about is that inevitable. One of the things that's said about aged care all the time is people need aged care because of social isolation, they're lonely. Social isolation is a result of health conditions causing a reduction in mobility and et cetera, et cetera. It's not the cause of the problem, it's a result of it. The social care system for older people isn't enough. We need to think about what you need in 5 different domains. How do I get the healthcare I need? How do I get the care I need to manage the functions of my life, activities of daily living? How do I get the social support and care I need? If I need residential care, because I can't live at home anymore, how am I going to get that? And how do I choose the place that can do that for me best? And at end of life, how do I get the palliative and end of life care that I need? So the idea that aged care is a lifestyle choice and we all go off is simply a nonsense. And it's not just accommodation and housekeeping either. We need to think about all those domains in our lives and identify what's going to work best. So this is what I call the 5 domains of aged care. They're all equally important and they're all interconnected. And this is why the split between the Commonwealth and the state is so problematic. Dimity is funded by the Commonwealth, but if you send somebody to hospital, that's funded by the state. And in my region, in the Illawarra, we have a major crisis at the moment. 20% of all of our hospital beds, public hospital beds, funded by the state, are occupied by people approved for nursing home care. 20%. So we've got almost no elective surgery going on because the medical patients are in the surgical beds and all the people who should be in aged care are in the medical beds. And that's not a problem for the Commonwealth because they've cost shifted 150 people a day onto the state. They think it's terrific. So aged care is not a lifestyle choice. So when people say to me, I don't want to go to aged care, that implies that somehow or other it is a lifestyle choice. Well, nobody wants to go. You go to aged care when you can no longer live independently with dignity because of either cognitive impairment, typically, but not always dementia, or physical frailty, typically, but not always, loss of mobility. And we know what the typical pathway is. Somebody's at home just tottering on managing a long day today, has a fall or develops a urinary tract infection, ends up in hospital, and then that's the edge of, the thin edge of the wedge. We see that pattern all the time. Prevention's a really good idea. Love prevention, but we actually have to ask ourselves, well, what are we preventing? We're certainly not preventing death. And this is a really important point. We do want to stay fit and healthy in old age, but the idea that we can avoid death is ridiculous. The longer we live, the more likely it will be that we will become frail and develop cognitive problems. And that's a privilege of getting older. And the longer we live, the more likely that we won't be able to live independently. This is the age and sex profile of people in residential care last year in Australia, which is about 180,000 beds. And look what happens. There's almost nobody under 70. Most of those are young people with disabilities who've been stuck there for years. And as there's not that many men to start with, that's the blue columns. And as the years go on, they all die off, leaving we women, the stronger sex. So the average age at entry is 85. And look at this incredible number. We have nearly 4,000 people over 100 now living in residential aged care. So they did really well at prevention, but it will catch them in the end. This is what home care recipients look like. They're a bit younger, but they're not much. And there's much less people over 100 still managing to live at home. This is the frailty profile. And the people who are terminally ill got removed out of this. This is a study I did profiling people in residential aged care. And as I said, people who were terminally ill, we moved out of the study. The majority of people in aged care are severely frail. They're not there for lifestyle. And the idea you can avoid it if you become that severely frail is really naive. This is the percentage of people who need help from a carer in residential aged care. And you'll see that the lowest, people who can't eat on their own, not cook a meal, but actually eat it without assistance cutting it up and supervision and blah, blah, blah. That's 2/3 of people. The majority of people, 80% plus, can't do things like bathing and toileting and grooming. And this is their cognitive and social issues. The majority of people can't communicate and can't actually express their needs and etc. And I'm saying that because we really have to stop this myth that aged care is a lifestyle choice and I'm going to avoid it. That is the really bad way to think about your old age. And the young people in my family keep saying to me, well, if you need to, you're going there, you know, don't you? You better get it better, improve it beforehand. So I've got this. So I want to just talk a bit about the Act. Here's a few headlines about the Act. There is a new Act. It's now a bill going before the Parliament. It does have a strength and focus on rights, and that's good, particularly, as Anthony said, given today. I don't regard it as fundamental reform. I regard it as tinkering. The Commonwealth sees aged care as a competitive private for-profit market in which we give you choice and control. That's the rhetoric these days, to shop around and buy the services that you need. And if you don't like the services from one provider, you can pick yourself up and go elsewhere. And I just showed you the profile of the people in residential aged care, and that might work if there are strong family members who can advocate. But that is not actually what ageing looks like in Australia. There is an attempt. This is moving on itself by itself. Oh, you're doing? Okay, I'll get you to go back. There is an attempt at the moment to increase supply of home care in order to reduce demand for residential care. And remember, it's only 14% anyway. And there is an attempt and a budget projection to actually reduce it. But luckily, last year, Minister Mark Butler announced that CHSP was being left out of the new program, for which I am eternally grateful. And I have proposed in the submission yesterday that we actually continue to lobby to ensure that CHSP, that is grant funded, not for profit, services we trust from churches and trusted organisations like Meals on Wheels, et cetera, local councils, et cetera, that those sorts of organisations should remain as the major deliverers of older people's services rather than private for-profit multinationals. The main change that the government's proposing is that consumers with the means to do so will pay even more than they're paying now. And I believe they got the numbers wrong in terms of the amount of money that they think they will be saving. And I'm not going to try and list the changes, but I'm very happy in panel later to discuss some of them. Anthony, I'll move you on now then. Thank you, seeing that this one's stopped working, but I'll still use it as a pointer. The new supported home program is a program to help you stay at home. You'll be assessed and you'll be given a budget at one of 8 levels based on how well you can manage activities of daily living and some other factors. And 10% of it will immediately be scooped off the top to manage the administrative side of it. And the most you can expect to get now is $78,000, but after you've paid your 10% in case management fees, you'll end up with $70,000 a year to stay at home, which sounds a lot, sounds great, but that's going to buy you about 17 hours a week. And there's for those adding this up in their head, there's 168 hours in a week. If you live alone, 170 hours is a long week to have somebody in your house, maybe 10% of the time, and that's the most extensive support you can get. There are also 2 short-term programs, which I'm very pleased to see. One is a restorative care project. If you've been in hospital and you've come out and you're deconditioned, remember that word, we go into hospital and the longer you lie around in a bed, the worse it is for you. Stay on your feet when you can. But there is a program called restorative care where providers can get 12 weeks of additional money, $22,000, to actually help you restore your function. And there's also an end-of-life pathway of $22,000 after the money's top scooped. And that will help, and that'll give about 20, and that's only for 3 months. If you don't drop dead in 3 months, you got an extra month. And then after that, you're back off that program and you're back to the others, which is, I'm sure there'll be a lot of people who are not tidy enough. But anyway, that's how it works. This is my last slide, and I know that there's a whole lot of questions you've been asking, but I want to ask some myself. I love this, old lives matter. My first is, where do the rights of older people fit in a competitive for-profit market? And how do we reconcile a focus and a set of rhetoric around the rights of older people with the whole move towards competitive market providers, where some of the biggest aged care providers, Opal and Bupa and all of those, are seen as too big to fail? Can consumers really shop around? And I think the other thing that I keep saying to people, we know this from all the research I've done and everybody else, older people want relationship-based care, not transaction-based care. They want someone coming in. If I'm having someone come into my home, I want to have a relationship with that person and trust them. I want them to be kind and trustworthy and competent, not be there because there's a commercial imperative. And I think that issue about how do we balance rights in this marketplace is really important. The next is about community engagement and volunteering. One of the backbones of our society caring for older people for the last 100, 200 years has been community volunteering. I'm on the board of Meals on Wheels. We lost lots of volunteers during COVID. Why would anybody be a volunteer in the new private for-profit competitive market where volunteers are being seen as workers, having to meet all the standards, etc. But it's more than that. It's really about culture. The best way to have a healthy society for older people is to have a supportive community environment where we depend on each other. And when we commercialise ageing and commercialise communities, we really weaken society, in my view. And my third issue is, even though some people, I'm pretty sure, subject to not developing dementia, I'll be able to navigate the aged care system. But what happens to those who can't advocate for themselves, and what systems do we need to put in place? So they're my opening comments, and I'm giving you a lot of detail with graphs and stuff, but I'm very happy to answer questions about those in the panel. Thank you, Anthony.